So how about this? Let's chat about GDMT.
Okay.
All right. I really want it to be interactive if you can, a little bit. What is the GDMT, or what are the GDMT medications for HFpEF?
Beta blockers.
Wrong.
Cardavitalol.
No, wrong. So really, we don't have GDMT for HFpEF. Okay, the only medication tried and proved to be to improve or affect survival was the SGLT2 inhibitors, Jardiance and Farxiga, both medications. There's some little bit data about aldactone, didn't really make it to as the GDMT, but the main issue that you need to target in this kind of patient population is to control hypertension and obviously fluid management, risk factor modification, obesity control, sleep apnea control, and so forth. But as far as GDMT, we really don't have many or any besides the SGLT2 inhibitors.
Okay.
And I don't think it has been incorporated directly in the guidelines, similar to the HFrEF patients. So just keep that in your mind. We thought before that controlling heart rate and decreasing heart rate is going to increase the time that you're going to have your patient in diastole. So you're going to increase the time that your filling is going to be happening during the cardiac cycle. Turned out that actually that was a mistake, because when you decrease the heart rate in this patient population, you're going to enhance the issue, which is diastasis, and your patient is going to do worse, actually. So guess what? In patient with HFpEF, a little bit of increase in heart rate is actually not a bad idea, unless obviously you have atrial fibrillation and so forth. So when I was in training in cardiology in 2010 until 2013, actually, decreasing heart rate should be the target, because we thought that improved the time that patients going to have the time in diastole, but turned out that actually exacerbated the issue, and we don't do that anymore. So be careful, your patients with HFpEF, not to be too much bradycardic.
Okay.
That's not a bad thing to know. How about HFrEF? Number one.
Okay. Beta blockers.
Right.
Beta blocker, cardavitalol, or glucosinate.
Exactly right. Then number two.
ACE inhibitor.
Right. Or
Entresto.
Or
ARNI, which is the Entresto, right? Sacubitril valsartan, or ARB, right? Number three. That's actually ACE inhibitor or ARB, and ARNI. Number three or number four.
Aldactone.
Right. MRA. Right. Aldactone, Plirinol, aldosterone inhibitors. Number five.
Farxiga.
SGLT2 inhibitor.
Right. So always remember that. So GDMT, if you're not going to place your patient on GDMT therapy, you have to justify why. Potassium is high. I wasn't able to put my patient in Entresto. Patient has been hypotensive. I was not able to add aldactone, and something like that. It should be justified somehow in your note. And remember that the clinical trials were done as the beta blockers were the number one to decrease actually mortality number needed to treat, but these medications were a long time ago, so we didn't have that much medication. So number needed to treat was about 9 patients. But I would go with this, beta blockers, Entresto, MRA, and then which is aldactone and aldosterone inhibitors, and then then you go into the SGLT2 inhibitors. Okay. When do you have, when in patients with HFrEF, when do you recommend AICD or BIV ICDs? Can you give me the ICD indications and the BIV indications? Anyone? What is the EF?
Less than 35.
35.
Less or equal than 35. What is the QRS duration for BIV? 150. So look, it's a little bit granular here, a little bit. So if you have non-specific interventricular conduction delay, or you have right bundle branch block, should be 150 or more. If you have left bundle branch block, should be 120 or more. However, you have to have class 3 or 4 heart failure, and the class 4 should be ambulatory heart failure. So class 4A, it's called class 4A, ambulatory heart failure, not patient half dead in the hospital, right? But the wider the QRS duration, the better the outcome. And for you guys, I would not really consider BIV upgrade or BIV ICD unless you have 150 millisecond or more. If you have typical left bundle branch block, then 120 or more, maybe in the case of class 3 heart failure. Now, patients should be on GDMT, right? For at least 3 months. And if the EF does not improve on GDMT, then this kind of therapy is indicated for primary prevention. I'm sorry. Now, how about the life vest? Do we use life vests? No, we don't really.
No.
There's no data about life.
Please, no.
Right. So no data about life vests. The only time I use life vest in case of device infection, patient have to have device removal. Then during that time where the incision needs to be healed and so forth, then life vest is reasonable. But short of that, actually, is not. And remember, in case of device infection, the number one mortality is going to be not related to cardiac arrest, it's going to be related to infection. Just keep that in your mind. It's terrible. It's terrible. Elderly patient population wearing a life vest is just horrible. I've seen actually pressure ulcers in the back deep from wearing this life vest. And all our colleagues, the interventional physicians and general cardiologists, they just get scared and they want to order this. It's really not supported by guidelines. How about GDM?
Can you go over, oh, I was going to say, can you go over sort of like, I find that my patients are very uneducated about AICDs, and they come in wearing the life vests. And once I explain that it like doesn't increase quality of life or prolong, like they all end up taking it off because they're like, this thing's awful. I mean,
Right.
what are the actual like those sort of things? I'm trying to think of, like, I've explained it to patients, but as far as the data goes.
So the data goes, it doesn't really appear in the guidelines, right? And we're on the last clinical trial, they took patients with massive MI, especially anterior MI, in the setting of non-sustained ventricular tachycardia. And they found the mortality was similar, but the cardiac mortality was less in the live vest patients. So basically, mortality is similar to the Dynamite trial. The Dynamite trial, they took patients after MI directly, MI non-sustained VT, slammed them with ICD, right? And they found that the cardiac arrest from, or the mortality from cardiac arrest arrhythmia related was less in the ICD arm, but the survival overall did not improve. So this is why it's not really supported by guidelines and contraindication to do ICD right away, right? This is why you have to wait 3 months. The life vest is really the same. So life vest did not really improve survival at all overall. And this is what we have to do. So it's a matter of shared decision with your patient. You can provide your patient that really did not improve survival. Sir, that did not improve survival in clinical studies. It's really up to you. Want to use it or you don't want to use it. As you know, in medicine nowadays, we're moving into this shared decision modality where you got to educate your patient about risk and benefit, and you have your patient, you share the decision with your patient. You cannot impose your opinion about your patient. And for the life vest, I would say there's really no data to support using life vest, sir. And if you want to remove it, I'm okay with it. In fact, I wouldn't use it.
Okay. I mean, that's what I normally say. I just wanted to make sure.
And again, the one study ischemic massive MI. Look, massive MI, EF less than 30%. Non-sustained VT on heart monitor during the first 48 hours after the MI. And in that case, did not even improve overall survival. So, but you know, us, we're really physicians, the fear aspect, cover as medicine aspect of us ordering this kind of stuff, but we should be the advocate for our patients.
It's a fall risk too, with all the elderly people and the cords and everything.
Well, and they don't understand how to use it. Half the time they're not alert enough to press the buttons if they're not on right, and it drives the nurses crazy. Most of the time I have patients that it's totally inappropriate for all of the reasons.
You will never get sued by any entity if you remove the live vest from any patient, because we really don't have data to support it. We do not have data.
Didn't you tell me that
Interesting.
if a patient is fitted with a life vest, they probably just have a low EF? Because
Right.
if they had VT, they get it depicted.
Right.
And the chance of them having cardiac death VT within the first year is like less than 2%.
This is why actually ICDs are not so when you get this is actually a very, very good point. So when you advise your patient about AICD, that's from the guidelines based on and that's actually extrapolated from the companion trial, from the SCOT-HIF trial, and from the MADE-2 trials. So they have to have at least 1 year survival to be able to get benefit from the AICD. Why? Because you know AICD is not gonna do anything in the first year after the initial event, which is, you know, the diagnosis of EF of 35% or less. So you have to have a patient with good acceptable functional capacity, able to make decision, able to give you consent. Patient should not be bedridden, should not have bilateral extremity amputation and living miserably, that you're prolonging the survival of somebody who's miserable. So you have to have certain criteria for patients to justify for this expensive therapy. And we know why don't we do ICDs on patients with class 4 heart failure? Because they're gonna die from pump failure more than arrhythmia issue related to the decreased EF. So always think about that. The problem is, you know, I was in practice before, after out of training, and every EF less than 35% just that should qualify for life vest. That was a mistake. That was a mistake, and that's tunnel vision, and that's uneducated physicians or physicians who are too scared. They can jump into stuff like that. But, you know, for us, we have to practice evidence-based medicine, and we should be very careful about utilizing such therapies. Any questions about that?
I thought I heard something about they have to wear the live vest for 3 months before the actual implant. Is that true?
Say that again.
I thought I heard they have to wear the live vest for 3 months before the actual AICD implant. Is that true?
No, ma'am. No.
Mm.
It's never done in clinical trials as such. It never
Okay.
done clinical trial as such. This is us physicians practicing this kind of medicine. So you have to be GDMT for 3 months, at least 3 months, then get another EF, then identify the EF. If the EF, get another echocardiogram. If the EF less than 35 or equal or less than 35%, class 2 to 3 heart failure, or class 1 if you have ischemic cardiomyopathy EF less than 30%. In that case, you should qualify for ICD. But, you know, life vest is not in the clinical trials. Is not expensive. It's $3,000, $4,000, $5,000 a month you have to pay for this kind of machine, and they are you know, playing with fear, basically. You know that this modality can protect you from dying suddenly after your cardiac event, but guess what? Is not actually.
So the 90 days is more of insurance?
No, the 90 days actually, because it was clinical trials. So we have the MADE-2, okay, 90 days. We have the SCOT-HIF 90 days, companion trial 90 days, right? And the guidelines, thus Medicare pays based on the guidelines and based on the standards of care and based on clinical trials. When they did the Dynamite trial, let's implant ICD right away after your event and see if that can protect. It did not do anything. So this is why, you know, first first 3 months, you're not gonna really die from arrhythmia related. You're gonna die either pump failure, or you're gonna die from device related issues, or you're gonna die from ventricular rupture or some kind of complication related to, let's say, your massive MI, but it's not gonna be the ICD. So remember that ICD is gonna, even if your arrhythmia is bad enough, the ICD is gonna shock you 5-6 times and it's gonna stop. So, you know, the ICD is not, you have an insurance for the rest of your life that arrhythmia is going to be treated. No, it's much more complicated than that.
So they
Okay.
need to have 1 year, they need to have 1 year from the
Of
event
1
of their
year,
MI, and
1 year,
they also need 1 year of quality of life left. Is that
acceptable quality of life. The way you see it
okay?
as a physician as acceptable, and it should be shared decision.
Okay.
So acceptable lifestyle, not somebody who's peg tube and trach, not somebody who's miserable, severe depression, not somebody at
Right.
age 94 that he's screwed up. You know, life is miserable. So it's not somebody who is reasonably active as a 78 or 82 or 65-year-old guy or lady, and those are the patients that can benefit from this kind of expensive therapy.
Okay. Thank you.
Anything else about this point?
Mm-mm.
What is the GDMT for CAD disease?
Antiplatelet, beta blocker, statin.
Statin.
Exactly.
Yeah.
Right. In fact, if for stable coronary artery disease, beta blockers are really not becoming very favorite for us, but you know, we still use it for angina treatment. MI patients beyond 1 year to 2 years, the beta blockers benefit goes away, but we still use it. So if you feel that your patient cannot handle beta blockers after 1 year of your MI or after year of stable CAD disease, then feel free to stop it. We should be fine. But statin and aspirin are the key.
Okay.
How about peripheral vascular disease, either carotid or lower extremities?
Aspirin and statin.
Exactly right. What is the new goal for LDL in patients with CAD disease, what we call high risk? If you have hypertension, CAD, peripheral vascular disease, CAD, or you have history of stroke and CAD, or diabetes and CAD,
Less than 50?
55.
70.
55,
55.
the new guidelines.
Okay.
And I remember when I was in training, one of my mentors, that was 2008, used to tell us, if you can't keep your LDL below 50, you'll never have CAD disease, like similar to horses. And you know, the guidelines back then saying less than 100, right? So he was really targeting, and fast forward, the guy died actually. His name is James Willerson. And fast forward, 15 years later, you know, the guidelines actually said now it's less than 55. So just to let you know that lower is better always.
Okay.
Hey, Dr. Ibrahim, have any dietary data, has that changed since they
No,
have said no saturated fats and all that? You can
No.
see how people are trying different things with bacon and butter and
no. Look, the only diet that made it to guidelines, Mediterranean diet or DASH diet. Okay, there's really nothing else, because diet is extremely difficult to test and extremely difficult to try. And there are a lot of other factors: how much food you're gonna eat based on your BMI, how much calories you're gonna take, what kind of calories, is extremely difficult. I've read on New England Journal of Medicine some little bit data about intermittent fasting and so forth. What I tell our patients, oh doc, do you have a diet? As if we're magic. No, we don't have a diet. Just you need to eat healthy, avoid eating after 7 p.m. Olive oil is good. Avoid saturated fats, avoid carbohydrates, and be reasonable in what you eat. Like for instance, I've probably, whoever works with me in the clinic, you know, I had a lady came into my office one time, told me that her doctor, primary care physician, told her to be carnivore, like eat only meat. And then 6 months later, and I really, I'm not making that up, came into me. So I told her, hey, tell me about this, about your doctor, the meat eating guy, 62-year-old, 63 years old physician. She told me, oh, you didn't hear that? He died of massive heart attack. So the point is really be reasonable and sustainable.
Yeah.
So, not 100% meat, not 100% vegetable, not 100% cut. We know that carbohydrates are bad. Sugar is bad. Eating after 7 p.m. is bad. Larger meals, not good. In terms of weight loss, what I find that calorie count may help, right? So all of this stuff can help, but we do not have dedicated diet, even in Coumadin. Do you know that? We don't have diet for Coumadin. We just tell patient eat reasonable and eat sustainable. If you want to eat your vegetables on certain days a week, so be it, right? Not like you have to avoid the green because green has vitamin K in it and that affects your Coumadin. No. Because we know that we dose your Coumadin based on your diet, medications, and other factors, and that's reasonable to do stuff like that. And we don't have certain diets for certain diseases. We don't do that anymore.
Thank you.
Any other questions? I think that's good. That's informal kind of lecture, interactive. Thanks for just interacting, guys, and having questions and having this kind of dialogue. I think that will help. And if you have any more topics we can chat about in the next 3 weeks or so.
Okay.
Yes, thank you.
Thank you.